Hello. Today we're going to be looking at consent. It's one of the major concepts within the patient-provider relationship. And I want to begin by introducing a new concept that moral philosophers, ethicists, bioethicists often reference, and it's called the notion of a prima facie good. And we saw them in examples. If you've done the reading for the normative ethical section, you may recall that one of the philosophers in the deontological tradition introduced this notion of a prima facie concept. And what a prima facie is, just to remind you, is understood as a first consideration. Literally, prima facie means first face. And so it's a consideration that you ought to consider before doing any kind of further computation or calculation or assessment of any case. So, as an example, you might consider certain rights to be fundamental, the rights of non interference, the rights to certain goods and services that are integral to being human or to being a citizen. As such, consent seems to be one of those. And consent is a formal concept, again, found in virtually every moral code, certainly all modern moral codes that govern professions. And consent is achieved when a patient or a client is fully and adequately informed of and also understands the implications of a treatment, a diagnosis, the costs, the side effects, both short and long term, of any medical procedure, and then agrees to that without coercion. And the stronger version of informed consent is understood as being what any reasonable patient would want to know about their treatment and what any particular patient needs to know about their specific treatment. In that context, what we'll see is that consent is um, a very important concept within medical ethics. The uh, fundamental relationship works down if anyone is being coerced in any way, and patients always reserve the right of final refusal. Now, that doesn't mean that you can't do what you need to do to reasonably try to convince them otherwise if you believe that the medical treatment or diagnosis is actually in their best interest, but one has to be aware of one's boundaries and one's perceived levels of authority so that one does not, in fact, coerce a person. Now, there are different kinds of consent within the medical and healthcare communities. There's the kind of consent that you would understand as written consent. So, when you sign a document at your dentist's office or the therapist or the clinic that you go to, you're agreeing to certain precepts that are listed within that document, so a contract, if you will. There's also oral consent, and legally oral and written consent are tantamount. They're considered fairly clear agreements for a particular treatment. There's implied consent, which often occurs within the context of an emergency medical procedure where we may not be able to ascertain the patient's actual wishes, but we assume that the patient would want us to treat them in such a way. At one level, imagine a surgeon doing a surgery, having to fix something that has gone wrong during the surgery. They're not going to uh, you know temporarily patch you up and bring you back out of anesthesia and ask you should they do that. They're going to go ahead and do that, right? Or in emergency medical procedures, and first responders are often confronted with situations where they've come upon someone who is not capable of rationally making decisions. They could be unconscious, they could be inebriated, or what have you, and they need some immediate attention. And one may go ahead and do that, assuming that the person, if in a state of rational decision making capacity, would agree to that particular treatment, right? Uh, there's what we call general consent, which is the kind of sort of universal or parabolic consent you might give that would cover all the procedures of a treatment or a procedure. And then there's what we call special or sometimes experimental consent. This is where a person is voluntarily submitting themselves to a high risk or experimental procedure, say in a clinical setting where we're testing a vaccine or something, and there may be some risks involved. And if the person knows those risks and yet still consents to them, then they can be used as a subject. And of course, that last one brings up a very important historical reality that uh, where consent has been violated, it has given us, sadly, some of the history of medicine's most horrific and inhumane um, treatments of humans when humans uh, were operated on, experimented uh, without their knowledge or consent. We see that there's been a great problem. Now, it's a little tricky to read or interpret backwards in history, and because we have uh, better provisions today than they did, say, in the 17th or 18th century, but it still causes some very important uh, um, concern and really behooves us to understand the histories of these things, and particularly the larger history of medicine and healthcare. So, for example, one classic example of an abuse of consent would be Edward Jenner's intentionally giving bovine cowpox scabs to his neighboring Gloucestershire English farm hands to test his theory of inoculation, building on earlier theories of variolation. He, particularly Lady Ashley Montagu's variolations that she brought back from Chinese medical practices when she was abroad. Uh, Jenner thought that, well, he noticed that women working with cows didn't develop smallpox in the manner or virulence as others did. They may get it, but it would be a lesser form. And he reasoned from that that they had been exposed to cowpox. So he wanted to see if cowpox provided some kind of defense to smallpox. And so he put the scabrous material of cowpox pus under the skin of some boys and watched what happens. And we're told through the history of the anecdote that none of the boys developed smallpox, or if they did, they did not suffer the way that others did. And that, of course, leads to the whole theory of inoculation and vaccination that is central to one of the major aspects of public health strategy today in preventing diseases, contagious infectious diseases. Now, of course, uh, it's believed that Jenner didn't ask the boys. He didn't, and he certainly didn't ask their parents, and he didn't tell them of the risks. He, of course, didn't know many of the risks. So you have an example of a lack of consent. There, another example that is often cited in literature is the early 20th century example of Walter Reed, who, when he was working with the United States Army Medical Corps, knowingly infected U.S. servicemen with yellow fever without those soldiers' consent, and they were testing again to see the origin and cause of the terribly debilitating disease of yellow fever. Um, and what they did is they gave material that had been deliberately infected with yellow fever to see if servicemen were contracting it from using, say, soiled bed linens or what have you. And it proved not to be the case, and that eventually will lead them down the more profitable line of identifying the mosquito as the vector for that particular disorder. And so these are just a couple of examples. And later on in the course, we're going to be looking at some of the more inhumane and tragic examples that would come out of times, particularly where there are autocratic or despotic governments and doing them in times of war, like the well-known Nazi experiments. Um, uh, so our consideration here is that um, what we often find in these is that consent has been historically abused, and this will all lead eventually after World War II to a number of international provisions to guarantee the protection of patients, and particularly humans being used as human subject research. Um, uh, bodies, if you will. And of course, the Nuremberg trials would eventually lead to the international community adopting the Nuremberg Code. And that code, which you should take some time out to read and familiarize yourself with, is really built upon the principle of informed consent. Uh, so when we think about consent, we're thinking about providing a person as much information as they reasonably can understand. And very important aspect here is the concept of voluntary. What do we mean by voluntary? Well, certain forms of pressure might force a person to make a decision, particularly when you recall that a person with seeking medical care is often in a time of crisis. They may be suffering, they may be in pain, there might be psychological aspects that make them more impressionable than they would otherwise be, and so those need to be taken into account. And if you are in any way coercing an otherwise autonomous human being into a procedure, there's something unjust occurring at that point. To understand the context of a person, their psychological well-being, their rational decision-making capacity, and their level of knowledge is very important. And that's one thing that I'd like to remind us all of here, is that as public health officials and medical professionals, and you're going forward in your career, always be cognizant of your own level of understanding, which is going to be far greater in virtually all instances than your patient. You are investing in and spending a great amount of time learning very sophisticated vocabularies, technologies, techniques, which the average person is not going to understand. And so there's a tendency to speak in a kind of medicalese, and that's a very problematic, because that can bowl over a person, that you can lose them very quickly. It's often been said that, the sign of true wisdom is the ability to speak clearly and without the arcane vocabulary of a tradition. And I agree with that. I think it's something that we can all learn from. So remembering to get back to the mind of your patient where they are, and speak to them in a way that's accessible to them, I think is key in providing the information that will allow them to think about and make decisions and provide consent. Now, of course, this isn't, asking you to dumb down your practice, but there are ways that you can approach it in such a way as to make it accessible. So if a person is voluntary, it means that that person's making that decision without the interference of any pain or suffering, that there's no undue authority coming from you or any other authority figure in that person's life. Uh, Family members are not pressuring them, their spouse is not pressuring them, they're not in an abusive relationship, they're not overriding financial concerns, lack of insurance that might be pressuring them to get or not get a procedure. And there are a variety of ways that we can solve any of those problems. Often we tend to find human beings thinking in binary moments where, either get the disease and pay loads, or go broke or die, that sort of thing. And there's often a third alternative, right? We can often provide financial counseling to a person if financial aspects or lack of insurance is the issue. So always being aware of and offering the full resources of the clinic or hospital that you're working with toward that is a good way to allay some of the concerns that might otherwise uh, force or coerce a person to make a decision that is against their uh, true interests. One really fascinating case study that you're going to be looking at is the case of some patients who undergo a severe or massive cerebrovascular stroke that leaves them in what neurologists call the locked-in state. The person may be paralyzed from head to toe, but their minds, and therefore their rational decision-making capacity, may remain intact. And, such a person may only be able to, say, move a single eye. And, imagine a situation where the person is considering to either forego or to continue future treatment in that state. Would you believe that if you could establish some form of communication that could be checked, that the movement of eye would be sufficient for informed consent. These are the kinds of things that become very problematic in these sorts of fields. Okay, so that's consent, um, and we've looked earlier at confidentiality, and we'll continue looking at some of these fundamental relationships within the context of the personal patient relationship. Goodbye.